Hi, everybody. Thank you guys for joining today. My name is Greg Pereira. I'm a hand, wrist, and elbow surgeon at OrthoCarolina, and I'm in the Mooresville office. Thank you guys for joining the OrthoCarolina webinar series. Today, we're going to be talking about carpal tunnel. So I encourage you guys to ask questions or write questions in, and we'll answer them at the end. But thank you all for joining. So a little bit about myself. My name, like I said, is Greg Pereira. I'm a North Carolina native. I grew up in the Triangle area, Chapel Hill, Durham region, and I went to UNC Chapel Hill for undergrad. I went to the University of Pennsylvania for medical school, came back to North Carolina at Duke for residency in orthopedic surgery, and then I did my fellowship here at OrthoCarolina. So today we're going to cover carpal tunnel. We're going to start with diagnosis, go to the risk factors, management, surgery, and then outcomes. So really here, what is carpal tunnel? If you kind of do a cursory search on Google or, name your favorite WebMD, what it'll probably say is it's a compressive neuropathy of the median nerve at the wrist. So getting into that, what does that actually mean? For compressive neuropathy, that means it is squeezing of this nerve here, which you can see in yellow, the median nerve, as it goes from the wrist, if you can see my cursor, kind of into the hand. It crosses this anatomic tunnel, and then subsequently you get these symptoms in a classic distribution where you can see here thumb, index, middle, and half of the ring finger. And we'll get into those symptoms. But again, just think nerve compression going from the wrist into the hand, and then you get symptoms in typically a classic distribution, though it can be a little bit different from person to person. So kind of going back, this is kind of a cross-section view. So if you looked at the wrist, you can see there is this anatomical tunnel. In the tunnel, there's certain tendons that go to the fingers as well as the nerve. And here kind of outlined, there's some of the wrist bones as well as this asterisk is a ligament that kind of crosses over the carpal tunnel, making the anatomic tunnel. So here you can see that you get narrowing of this tunnel, which leads to compression of the median nerve, and then subsequently you get symptoms distally or kind of out towards your fingers in your hand. So what are those symptoms? Most patients come and talk about numbness or tingling in their hand. Some people talk about burning or pain. And as we showed before, this distribution, thumb, index, middle, and half of the ring finger, is what we usually think of the median nerve. So it can be a little bit, sometimes people can have other conditions or other compression in other areas where they can get symptoms elsewhere, and there's not a perfect one-to-one overlap. But if you're getting numbness in the thumb, index, middle finger, this is, again, definitely something we're thinking. As carpal tunnel gets worse, so as that compression gets more severe or persists for a longer time, patients can get weakness. And although it's primarily a sensory nerve at the level of the hand, in in this kind of meat of your palm, those muscles, we call them your thenar muscles, are innervated by that median nerve. So again, that compression gets more severe, you can get weakness of those muscles. And that can lead to difficulty with some of those fine motor tasks of your hands. Now, also, this is something that we oftentimes note patients say is worse at night, or they first notice their symptoms of nighttime, because that's a common time when we sleep. We sleep in a flexed posture, and flexing your wrist will inevitably make carpal tunnel worse, because it's partially postural there. As you flex the wrist down, the tunnel narrows. So that's, again, something that if you hear symptoms worse at night, numbness, burning, tingling in this distribution, you tend to think something like carpal tunnel. So as we're diagnosing it, we ask you all those questions. We get a history, right? Which of those symptoms that we just talked about, numbness, tingling, and burning, are you feeling? Is it worse with wrist flexion? So it doesn't just have to be sleeping. It could be something like driving, where your wrists are flexed over the steering wheel, or anything, power tools, etc. There's certain activities that worsen your symptoms. And then again, we think about the distribution. Now for the physical exam, we do a typical, just general hand exam, because we try to rule out other things. But for the special tests that we do for carpal tunnel, most of them really aim to, again, either tap on or push on the carpal tunnel. There's a lot of different tests that have been described, but on the top you can see tapping on the carpal tunnel. kind of that area of the wrist they're tapping on can create symptoms in your fingers, or pushing on it and flexing it down is another common one you'll see. So we do those tests to kind of, again, they're kind of provocative tests to help exacerbate or worsen the symptoms that you may be experiencing at other times. The other thing that we often do is get what's called an EMG and nerve conduction study. That's a study where you use these little pads and little needles and you run an electric current down the arm, and your nerves, they kind of transduct that electric current. And if there's compression, it slows it and alters it. So it gives us more kind of objective data outside of our history and physical exam that you're having some compression of the nerve, and also where that compression may be. The other thing is it allows us to kind of delineate, is it mild, moderate, or severe? So we can kind of look at how bad is the compression, and that can help us give you guys some answers as when you may receive relief. And, for some of the things about, for example, weakness, will you get any strength back? When will your nighttime symptoms resolve? And it kind of gives us more prognostic information. So when you look at this picture, this is kind of a caveat with very severe carpal tunnel. One question I get is, what if I do nothing for carpal tunnel and you leave it for a long, long, long time? You get severe carpal tunnel and it becomes a chronic condition. So what happens is, as we talked about earlier, although the nerve is mainly sensory, it does innervate the muscles of the thumb. And over time, those muscles of the thumb, if the nerve is compressed, start to kind of wither away or atrophy. And that actually becomes permanent weakness. That does not come back even after we do a carpal tunnel release. So that's something to consider. And part of why we do the carpal tunnel release for these folks still is we want to preserve what they have. But that's, again, this is very advanced carpal tunnel in this picture. So for risk factors, there's a slew of associated medical conditions, diabetes, thyroid disorders. We talk about inflammatory arthropathies. That's things like lupus and psoriatic arthritis. Those things are definitely have an association with carpal tunnel. Obesity and female gender are also associated with carpal tunnel. And sometimes we also see it in pregnancy, though in pregnancy, frequently after giving birth or delivering your child, those symptoms go away. Also, in people who do repetitive wrist flexion activities for work, whether it's people, truck drivers, or, people who do activities where their wrist is flexed a lot, they oftentimes will say they're having some of these symptoms. And that's something that we've seen. So we'll begin, because most of the time when I meet folks with carpal tunnel, we oftentimes try and start with non-operative treatment, which I think is a very, very reasonable place to start for the overwhelming majority of people. So that is typically wrist splinting, and particularly at night. The goal of the splint isn't to undo the compression. The goal of the splint is to keep your wrist in a neutral position where you're not in flexion. So at a time when you're, let's say, sleeping, it prevents you from flexing your wrist down. If you don't flex your wrist down and you have, kind of mild symptoms, it may alleviate your symptoms altogether. It doesn't undo the carpal tunnel, but if it gives you symptomatic relief, I think that's a win. Steroid injections. Steroid injections do a lot for us in hand surgery, but steroid injections for carpal tunnel can provide some temporary relief. It is kind of, from our medical literature, something we know is more of a Band-Aid, meaning it will almost certainly come back at some point in time. But for folks, who have life events or who are, trying to avoid surgery, I definitely think it's a reasonable thing to try. I also think for folks with symptoms that, may be due to neck pathology, or maybe, they maybe have multiple sites of compression, doing it can be both diagnostic and therapeutic, meaning it can help tell us how much of the compression that your nerve is experiencing is from your wrist, and it also provides some relief. So I definitely think it's a good has a good place in my treatment algorithm, although it is truly, again, more of a Band-Aid. Non-steroidal anti-inflammatories and oral steroids are definitely other options. I will say the reason I put an asterisk next to oral steroids is oral steroids have a slew of other side effects, and they have a harsh side effect profile. So I try to stay away from like the prednisones of the world in my treatment algorithm. And, it's just something to consider whenever you're taking medication. What side effects will you get? Again, this is temporary relief. Ergonomic changes are things that, our medical literature doesn't have too much on ergonomics, but I will say for folks who work in specific jobs, I'll show you some pictures of this, and they have symptoms with specific tasks. If you can get a more ergonomic device, whether it's a keyboard or a mouse, it's worth a shot. And it kind of works similarly to a wrist splint in keeping your wrist in a more neutral position. So for a carpal tunnel steroid injection, it's an in-office procedure. Do it all the time, and really what we do here is we clean off your skin. We obviously sterilize it. We wipe it off. Sometimes use a cold spray. I personally do that. Some folks have different opinions about that. But then essentially we inject the steroid and lidocaine directly into the carpal tunnel, obviously not into the nerve, but that local steroid acts to decrease inflammation, and that can kind of increase the relative space in the carpal tunnel, which again tries to alleviate your symptoms. That being said, again, it almost certainly will come back, and it's less likely the more advanced your carpal tunnel is. These are some ergonomic devices that patients have definitely talked about, that I've had, and have showed me that they've experienced good symptomatic relief. So for example, the mouse, that mouse keeps your wrist kind of in a straight neutral position. And for folks who work behind a desk, who really say their symptoms only occur when they're using their mouse, I think it's very reasonable. There's an ergonomic keyboard as well. And again, I think it's worth a shot. So now, as far as as far as our treatment recommendations, this is from the American Academy of Orthopedic Surgeons. They look at the overall kind of our overarching body of medical literature, and they create recommendations that help us kind of guide our treatment. So the American Academy of Orthopedic Surgeons came up with this strong recommendation, which says there is strong evidence to support the surgical treatment of carpal tunnel should have a greater treatment benefit at 6 and 12 months as compared to splinting, nonsteroidal anti-inflammatories, therapy, and a single steroid shot. So that really is saying that treatment of carpal tunnel with surgery at 6 and 12 months is really results in kind of better improvement and better treatment gains than the non-operative treatment. So with that being said, you may say, so when should you consider surgery, or why wouldn't everybody just get surgery? And I think really my answer to that is, this is a great recommendation. I obviously respect and understand that there's a huge role for carpal tunnel surgery, but one size doesn't fit all. So when I see patients, I know what the medical literature says, and my goal is to talk to you about the options. But I'll ask you questions like, how long have you been having these symptoms? Is it intermittent? Is it constant? Is it only with certain activities? Are we starting to see weakness and muscle atrophy? Because if it's more severe, that might push us more quickly towards something like surgery. Did we have an EMG or a nerve conduction study, and what did it say? Right? Are these symptoms predominantly nighttime, or like we said, are they constant? Can we use bracing to alleviate your symptoms if they're purely at night? Or if it's all the time, we might want to consider something more aggressive. So that again is what I call shared decision making. We want to talk about it. I have to inform you of the options, and then we come up with the best treatment plan for you. So jumping into surgical treatment, there's kind of two ways to do it broadly. One is what's called an open carpal tunnel release, where we make a small incision in the palm. The other is an endoscopic carpal tunnel release, which means we use a camera under the skin, and we can essentially use a deploying blade to release the carpal tunnel kind of from the inside out, if you will. So we'll get into more of those kind of fine details. But before we do that, this is really, again, it's important to understand the basic anatomy. So we kind of showed a similar picture earlier, and on the left, this is the carpal tunnel, right? So you can imagine there's these little bones, there's this ligament over top, and then there's the tendons and the nerve in the actual tunnel. As this relative space decreases, there's essentially squeezing of that nerve. It's kind of a chokehold on that nerve, right? And what we try to do, whether we're doing an endoscopic or an open carpal tunnel release, is we release the ligament on top. So instead of being a tunnel here, it actually ends up being more, if you follow my cursor, like a half pipe, if that makes sense. The ligament kind of springs back out, and then you're left with more room for your nerve, and your nerve can kind of, metaphorically breathe, if you will. So on the left side of the screen, you'll see what looks like an open carpal tunnel release. I do something very similar to this. And, essentially it's a small linear longitudinal incision in the palm. We use retractors to expose that ligament on top, and we release the ligament, with a scalpel. On the middle image of the screen, you see an endoscopic carpal tunnel release. So the endoscopic carpal tunnel release, you have a small incision in more of your wrist region here, and you use, again, that camera with a deploying blade under the skin, to release, again, that ligament, which, again, in this case, we're looking at with a camera. And there's been a lot of different, on the far right-hand side of the screen, a lot of different incisions that have been kind of described. You can see endoscopic is more close to the wrist. Open is kind of over the actual palm. And then mini open is very similar to open. It's just slightly smaller. And for endoscopic, I would personally use one incision. Some people use two, but I'm kind of more between like the endoscopic single incision and kind of the mini open, perhaps is probably the best way to describe mine. So for surgical treatment, we talked about the two ways, right? Open or endoscopic. But really, one thing I want to emphasize is one thing we offer at OrthoCarolina and I offer here in Mooresville is a open carpal tunnel release in the minor procedure room. So that's in the office, without anesthesia, without sedation, without narcotics. And really here, what the minor procedure room looks like is wide awake procedure under local anesthesia, kind of like you would have at the dentist or dermatologist. I think some of the benefits, right, are no sedatives and narcotics, which are very hard on your system. They prevent you from driving the day of. If you have a little baseline dementia or something, it can make you very delirious. It makes you constipated, etc. So that's obviously one major benefit. It's also significantly cheaper, and that's something I'll get into in this because I know that costs in healthcare can be kind of a black box, but especially if you have a high deductible plan, it's often, significantly cheaper to do it in a minor procedure room than to do it in the operating room. For faster procedure recovery, what I mean by that is if you go to the hospital or you go to the surgery center, you go to pre-op, then you go to the OR, and then you go to post-op. And all of that can take 20 minutes, it can take probably 3, 4, 5 hours. It can take half a day, to do all that. Versus in the office, you're probably there an hour to an hour and a half. So it's definitely a faster overall procedure. As I mentioned, you're able to drive yourself home because you didn't have sedatives or narcotics. So if you don't have, friends, family, loved ones, anybody in the area, it definitely allows you to be more independent and to not rely on somebody. And then just to, again, analogously, you can think of it similar to like removing cysts in the dermatology office or, basic dental procedures. And if you hear this acronym WALANT stands for wide awake, local anesthesia, no tourniquet. And that is kind of what we are performing in these minor procedure rooms. And without, the reason we're able to do this without a tourniquet is we use epinephrine, which is a substance that helps kind of create a bloodless field. So we can do it without using a tourniquet, which is, which would be painful on your arm. So no tourniquet for this procedure. Now, this is kind of the cost, right? So I tried to simplify this. So if you look at the left side of the screen, this is kind of the cost of carpal tunnel in a surgery center or the hospital. So this is if you go to the operating room for a carpal tunnel. You get 3 different kind of major costs. There's an anesthesia fee, there's a facility fee, and there's a surgeon fee. So the anesthesia fee is what the anesthesiologist gets paid to, put you to sleep and to monitor you as you're having the procedure. The facility fee is the fee to be in the operating room, and the surgeon fee is the fee for the surgeon who releases your carpal tunnel. Now, if you do a carpal tunnel in the office, there's no anesthesia fee because I'm using the local to numb you up. It's not considered like an operating room or a facility, so that eliminates that cost. And there really is just a surgeon fee. So without that, you can imagine 3 large costs versus 1 cost. It's significantly cheaper to do this in the office. So when we're comparing open versus endoscopic, first thing is this is from the American Society for Surgery of the Hand. You can see about 80% do either mini open or open, and about 20% are done endoscopically. But when thinking about symptom relief, they're pretty equivalent. So there's no difference in 3 months of your, with regard to how much relief you get for open versus endoscopic carpal tunnel release. Thinking about return to work, you have a slightly earlier return to work with endoscopic of 6 to 8 days, and you have slightly better grip strength and pinch strength within those first 3 months. The complication rates truly are about equal in the literature, and the cost inevitably will be slightly higher with endoscopic, especially since you have to do that in the surgery center or hospital versus being able to do that in the minor procedure room. So if you want a minor procedure room case, you cannot do it endoscopically as of now. For complications, it's a overall low complication rate for carpal tunnels. For major, I think major means, for me, a complication that requires you to go back to the operating room. So if you have a nerve injury, significantly less than 1%, but it's still been described. Infection, 1 to 3%. I think that tracks with a lot of other surgeries. But infection is probably the greatest risk of the major complications. And then really, this is an important thing to remember: severe pain at 1 year post-op, that's less than 1%. So most people are, doing very well at a year. These other things, a scar, everybody who gets an incision gets a scar. So naturally, you can expect a small scar in your palm, though it tends to fade with time. Short-term pain in the palm, we call it pillar pain. People get that oftentimes for a couple months because you had an incision in your palm. It's a highly innervated area. So, that tends to go away, though, very easily on its own. And inevitably patients, again, going back to this stat, at a year, less than 1% have any sort of severe pain. And temporary nerve irritation, when we're working around the nerve, sometimes you wake up and you get a little bit of those pins and needles, but frequently patients get pretty rapid recovery and it's relief of their pain at least. So for post-operative care, after I do this, you're in a soft dressing. That soft dressing can be removed after 5 days, but there's no splint or cast or any form of immobilization. As far as activities, you can do light activities. So you can hold a cup of coffee, use a remote, text, type, basic things less than probably 3 to 5 pounds. But I encourage you to use your fingers because I want to avoid stiffness of your fingers. So it's not something where you're all bandaged up and you can't do anything. You can totally use your hand, and we encourage you to move your fingers. I like to keep the incision dry until 2 weeks post-op, and the reason is because of that infection risk, right? Like, I think you keep the incision dry. I think people who keep it covered, honestly, again, that to me is kind of the gold standard. But at the same time, just keep the incision dry so we're trying to mitigate risk of infection. As I said, no cast, splint, or immobilization. And for pain, I think most people get really good results alternating Tylenol and then one of the non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. So every 3 hours, you're alternating so your body is seeing something, and that tends to really do a good job controlling the post-operative pain. The last thing I always say for any hand surgery is to elevate it. That decreases swelling, and swelling kind of goes hand in hand with pain. For outcomes, the numbness and tingling can be slower to resolve. So the more severe, right, we talked about mild, moderate, severe, the more severe your carpal tunnel is, the longer it will take to resolve. And typically I say it will continue to decrease until at about a year. And at that point it plateaus. So at that point you are where you're going to be. But if you're on the mild category, you'll probably have complete relief of your symptoms. Now, nighttime symptoms usually resolve. So that is one of the things that I actually love when many times patients come to us because they say, hey, I can't sleep at night. I wake up, I have to shake my hands out. I feel the pins and needles, and they hate that. So when patients come in, at 6 weeks post-op and they're saying, hey, I'm getting a full night's sleep and I don't have those symptoms, I think that's really gratifying. The one thing that doesn't resolve is weakness. So weakness tends to only occur in really severe disease. And that, as we showed, as that muscle withers away, it becomes more permanent. So the goal of carpal tunnel in any level of, mild, moderate, or severe severity would be to prevent progression, especially for weakness here, right? So the goal of carpal tunnel in the severe category is to help you kind of keep what you have rather than help you come back to a normal hand, because we can't regrow the muscle, but we can prevent more muscle from being lost. And similarly, carpal tunnel prevents progression of the numbness and tingling for here at the top, right? So our goal is to kind of keep what you have and try to get you better if possible. Frequently asked questions here is, when can I take care of my hand? When can I take care of myself? And that's immediately, right? You can use your hand for light activities, like we said, drinking a cup of coffee, holding a cup of water, like feeding yourself, etc. And your hand will be sore. So it's not going to be painless, but you can do it. And I encourage you to do it to avoid stiffness of your fingers. As far as return to work, there's kind of variable data in our literature, and it's going to be variable depending on the demands of your job, your pain tolerance, etc. But I'd say I've had patients go back as soon as 3 days, which, that's quick. But then our literature says that the overwhelming majority of people should be able to go back to work by 3 months. And that includes with some heavier demand jobs. So job demand and personal factors, that's something for you to take into account for yourself. And it's something that we can obviously talk about. But in general, most of my patients go back to work a lot earlier than that 3 months. When can you drive? Well, if you're done in the minor procedure room, you can drive immediately because you didn't get sedatives or narcotics. If you're done in the surgery center or the hospital, you did. So you obviously can't drive that day, but you can drive the following day. Remember, it's always illegal to drive if you're under the influence of narcotics or sedatives. So just something to keep in mind. And then when will it be painless? So again, it's a range. I'd say 3 months to a year based on our literature. Remember that 1 year, less than 1% of people are in severe pain, right? So it's very rare that people are having kind of chronic pain from this. My general thoughts here are most people do very well and are very happy they got it done. This kind of becomes for a lot of people, they get one side done and then they come back at 6 to 8 weeks and they're like, man, doc, my other side is numb and tingly. I want to get that done. And, we do it. So I think that's kind of a good benchmark. With that being said, no surgery is perfect and without risk. So it always is a risk benefit discussion. We individualize your care to your circumstances. And that is really the point of this third point here. We have the medical literature to guide us. My goal is to educate you and to give you the options, but then we use the shared decision-making approach to kind of help pick the options best for you. So with that being said, I hope that was helpful in kind of covering a lot of the kind of landscape of carpal tunnel syndrome. I would love to take any questions that you guys have. Okay, so the first question here is, when do you decide you need surgery for carpal tunnel? So, kind of harping on the shared decision-making approach, I think for me personally, I would decide I need carpal tunnel if it's disturbing my sleep significantly. One, if I'm having constant numbness and tingling, that would be very irksome and bothersome to my lifestyle. Two, and if there's any even remote sign of muscle atrophy or weakness, I would absolutely get it done. For me, I would also say though that if I'm having symptoms predominantly at nighttime, I would try a brace. Before I go under the knife, I would want to try bracing. I would want to try ergonomic devices personally. And I think there's definitely a role for all those things. And for people who are a little bit scared of surgery, which I totally understand, I'm happy to give you a steroid shot to see how much improvement you may get before you decide to do it. The one caveat I will say is if you get a shot, you can't get surgery within 3 months because it increases your risk of infection. So that's just something to keep in the back of your mind if you're trying to decide between getting the shot or not. And I'd say a lot of patients decide to skip the shot, or we would just kind of proceed with the definitive treatment if they prefer. So it's a little bit of a shared decision approach. So how does carpal tunnel differ from tennis wrist? So tennis wrist, different from like tennis elbow, which is tendonitis at the elbow, is kind of something that's like a repetitive overuse injury. If you're getting something like tennis wrist, that is going to be kind of a aching pain rather than, again, numbness, tingling, burning. And the timing of the symptoms, if you're doing something that's an overuse injury, is generally going to be when you're doing that activity, whether it's tennis or whether it's some sort of manual labor or whatnot, versus this tends to be in, again, sustained flexion moments of your wrist, sleeping, driving, things like that. So do braces really, the next question is, do braces really help relieve carpal tunnel pain? So I would say yes, they do if your symptoms are postural. And the best way to think about that is if your symptoms are only occurring sometimes when your wrist is flexed, the braces will help because the braces prevent that. If your symptoms are occurring all the time, it won't help you because by that point you probably have severe enough carpal tunnel that it's truly just squeezing to the point that there is no angle of wrist flexion or extension that will get you out of that. So I think it especially in the mild category in the early carpal tunnel, it has a lot of efficacy and it definitely has a major role in my treatment algorithm. Is carpal tunnel affected by trigger finger, and is there a connection there? So carpal tunnel and trigger finger are entirely separate pathologies. Some people with carpal tunnel will get trigger finger and vice versa. But anatomically, they're different. Carpal tunnel is kind of right in here in the base of the palm. That's where the anatomic tunnel is, and that's where the nerve is squeezed. Trigger finger actually occurs kind of up here, kind of right near the base of the fingers, and that's where a tendon goes through kind of, we call it a pulley, but it can get caught there. And that catching of the tendon at that pulley is what is trigger finger. So it's not necessarily, don't really, people will get both, but one doesn't cause the other. So, what treatment is there if surgery doesn't work? So, that's a great question. I see patients who have had surgery elsewhere sometimes come for a second opinion, and I think one of the ways to think about this, we have to get all the data we can, right? So, what I like to frequently do is get another nerve study, and if there was a pre-surgery and a post-nerve study, to right before and after surgery at some point, we can compare that because it gives us some objective numbers and some data which we can compare with the before and after effect. Now, if carpal tunnel surgery truly didn't work, we can always try a revision surgery, but I will say that revision surgery doesn't always get you complete relief. Because, as you know, one thing to keep in mind is if you have very severe carpal tunnel, you may never get complete relief, even if your carpal tunnel is completely released, because that nerve has been squeezed and crushed for so long, there's some permanent nerve injury there, right? So just because you had carpal tunnel release and you still have some symptoms doesn't necessarily mean the carpal tunnel surgery was a failure. What's a more relevant thing to think about is how severe was your carpal tunnel to begin with? The next question, is there a risk of atrophy of the thumb if symptoms are well controlled by wrist splinting? I wear my splint every night and I have almost no symptoms during the day, just occasional minor numbness. It's a fantastic question. And really here, no, because if your symptoms are only, occurring during moments where your wrist is flexed, you're almost certainly not in that severe category. I mean, we can get a EMG and nerve conduction study to prove that, which I think is not an unreasonable thing to do. But in general, most people who have that atrophy will also, describe this constant, persistent pins and needles, burning, aching pain sensation that is not really related to the position of their wrist. And they've kind of gone past that wrist splinting stage. Um, you can have moderate carpal tunnel, sometimes that still is responsive to wrist splinting, but I personally have not seen a lot of severe carpal tunnel that is very responsive to splinting. Next question is, can carpal tunnel cause pain, discomfort up your arm to the clavicle area? Feels like a tourniquet on my arm, only happens at night. So, carpal tunnel. So the way I think of this is, if the brain is kind of the power plant and your fingers are your light bulb, electricity kind of flows in that direction, right? So when people describe symptoms, kind of going from their clavicle or their shoulder or their neck down the arm, I oftentimes, and this is not always true, but the overwhelming majority of the time we think, well, there's probably compression of the nerves in your neck. You can get compression upstream from the carpal tunnel, and you can get radiating pain, and the fancy term is radicular pain. So that definitely can happen, and that is something that we see sometimes. There's a severe overlap. We call it double crush. Crush one here, crush two here, right? Now, in general, there's also other places you can get compression of a different nerve at your elbow, cubital tunnel, etc. So my answer to that question is, carpal tunnel, generally speaking, does not cause pain to go the other way, but it doesn't necessarily, there could be something else, whether it's neck or whether it's elbow, where the nerve is compressed. So again, that also warrants kind of a further workup, and that's something we work very closely with our spine colleagues on. Can both wrists be done at the same time? That's a great question. So people do endoscopic bilateral carpal tunnels. Sometimes I haven't seen very many people at all do bilateral open carpal tunnels. I will say, even with bilateral endoscopic, for me, like just, in seeing patients, I think it's nice to have one hand. You gotta, obviously, for sanitation purposes, for feeding yourself, for doing, your activities of daily living, as we call the basic things. I think having a, good wrist helps a lot. So I don't like to do it bilaterally. I mean, I know there's some people out there that do, and I think that's just a matter of, difference of opinion. But just keep in mind, especially if you're going to do in the minor procedure room, I'll never do it bilaterally, just because you need a good hand. Next question is, what, if any, impacts does carpal tunnel syndrome have on finger functioning? Can you close that? Yeah, so carpal tunnel syndrome, I mean, if it's severe carpal tunnel syndrome, the big thing is it's not as much your fingers as much as it is your thumb. These muscles right here can get weak, and that, again, can weaken certain aspects of, your grasp and your thumb function more than your fingers. The way it impacts your fingers is, they are, once it gets severe enough, they're going to be numb and tingly. And sometimes people drop things. Sometimes people, if your feeling is decreased, your kind of fine manual dexterity kind of goes down. But that is kind of how I would describe it affecting finger function. Next, does the endoscopic surgery have a less notable scar than the other? So good question. I think it does. I mean, it is truly a very small incision. Both, to be fair, are quite small, but the endoscopic, it's off the palm. So it's kind of right down in here. And the incision is, it heals up fine. Some people even just use like a Band-Aid or a very, very small dressing for the endoscopic incision. I will say though, if you look, it's pretty remarkable. After a couple of years, I've had patients who've had carpal tunnels done 5-6 years ago by somebody else. And when I'm examining the hand, it is very tough to even see a lot of open carpal tunnel incisions, because with time, it kind of pigments more naturally. And it kind of, it can be, you'd be surprised how many of your friends out there have had a carpal tunnel at least 5-10 years ago. It's just the way I think of it. Great. Next question. So do you need PT after surgery? In general, no. Like I said, the day of surgery, most patients, I'm having them use their hands. I want them to text. I want them to type. I want them to grab the remote. I want them to feed themselves, because that keeps your fingers nimble and it keeps them supple so that you can not get stiff. If this is not an absolute for me. So if somebody starts getting stiffness in their hand, I'll absolutely get them into therapy. And it's always an option that I'll give to you if it's the right circumstance, or if you want it, I'm happy for you to get it, but it's not part of my usual treatment algorithm. So the next one is atrophy inevitable, or eventually you will need surgery, or can it be prevented through home methods and PT? So that's a great question. Atrophy in general, I think as carpal tunnel worsens and becomes more severe over time, it can happen. Now, some patients will stay in that mild to moderate category probably a lot longer than others, and maybe never get to severe carpal tunnel to the point where they have atrophy. I will say though, there's no like home preventative or homeopathic way to kind of avoid this. I mean, this really simply is a mechanical problem over time, whether it's just increased inflammation in the carpal tunnel that decrease the relative space. There's even some protein deposition diseases that we've seen, in younger patients, where they actually have protein deposited in there, and that was what causes carpal tunnel. It is a mechanical problem, and the solution as well as a mechanical solution. Squeezing tunnel, go to kind of a more of a half pipe, right? But it's a great question, because for an individual, we don't have a crystal ball, and we can't say, well, you're mild now and you'll have severe in 5 years, right? Like, we don't know, but we can watch you very closely. And if you don't want surgery at all, my suggestion for those patients is still come back every year. Let's see how you're doing. Let's test your strength. Let's look at your palm and your thumb. And maybe if it starts to advance and progress, we can at least attack it early. Next one is, do any exercises delay the outcome of surgery? So, not really. For carpal tunnel, like I said, if you keep a better posture of your hand without flexing it down, you don't really get the symptoms, but that's kind of postural. It's not like strengthening. I mean, it's a great question, because a lot of things in surgery in general, if you strengthen the muscle groups around a joint, or you do kind of prehab, et cetera, like, it can really change either the outcome of surgery or even the need for surgery. Carpal tunnel, unfortunately, isn't really one of those things, but I think it's a very good question. Next question. If you have peripheral neuropathy, how does this affect any carpal tunnel or the relationship between the two? It's a great question. A lot of people have peripheral neuropathy. So when people have peripheral neuropathy, or like, let's say, neck compression, or some sort of a complicated picture, or a picture where it seems like there could be a few things going on, I like to get the EMG and nerve conduction study, because that gives us just more data. And the EMG and nerve conduction study can it can help kind of delineate some of those things. What is causing this? Now, peripheral neuropathy makes it challenging, right? Because you already have some permanent nerve damage, whether it's due to diabetes or something else. And it makes it a little bit harder to predict how much relief you're going to get after your carpal tunnel release. One thing I do in this setting to try to help answer that question a little bit is I'll give you a carpal tunnel injection if you can wait 3 months to get the release, and you're okay doing that. And if I give you the injection and it kind of decreases the inflammation around the nerve and increases the relative space, we can see how much relief you got with the shot, and that to me will help predict how much relief you'll get with the surgery later. So I think that's another way I try to tackle that when there's a little bit of those overlapping circles. The next one, how soon do cortisone steroids stop working? How many times is too many times to opt for the shot instead of the surgery? Any risks of long-term use of injections? So this is a great question. There's some things in hand that we actually kind of inject for a long period of time, like, base of thumb arthritis, I think is a classic one, right? For cortisone injections, there's a huge range. So some people have great responsiveness to the steroid injection. Some people have very little. I think one thing that definitely helps us kind of predict is how severe is your carpal tunnel. If you're having constant numbness, tingling, you have atrophy, it's probably not going to help you very much. And if it does, it's not going to help you very long. That's the severe end. If it's very mild, it may help you for a long time, which is, great. As far as how many injections to give, I personally don't like to give multiple injections just because thinking about, again, the carpal tunnel, it's a bunch of tendons in the nerve, and putting a bunch of cortisone in your carpal tunnel, I don't think is doing any, is probably doing any favors for that, for those structures, versus putting steroid in a joint, to me, with the exception of maybe increasing some, degeneration of cartilage, which is the risk of continuously injecting a joint. I think there's higher risks probably with doing multiple injections to the carpal tunnel. The other thing is, as your symptoms come back, your carpal tunnel syndrome is still there, right? And it's probably just worsening with time. You can kind of mask it with the shot, but at the same time, you're going to kind of, as you mask it, you're going to continue to progress. And if you get atrophy and we kind of miss the boat, I don't love that. So, a lot of us you'll see, and I've worked with some of the folks at the Hand Center and some of the folks obviously in other locations. They typically are not giving, 5-10 injections, something like that. But, it's again, we try to individualize it to you. And if you really want to avoid surgery and you want some injections, like, we can definitely try a few. Can carpal tunnel syndrome occur quickly? And then kind of as a secondary to that, can arthritis lead to carpal tunnel syndrome, or can they coexist? So carpal tunnel can occur rather quickly. I mean, some people, it kind of is a very insidious, slow onset, and it's, again, a variable kind of spectrum. I will say that I have some patients who, like, for example, are in pregnancy, and, they have a lot of bodily changes. And for those folks, it tends to come on quickly. But then there's some folks that come in and say, it's been started at night, and then over the course of a year, it kind of progressed. Now it's kind of constant, it's more on the many months to years range. So there's kind of a whole slew of kind of onset times, if you will. And the next one is, can arthritis lead to carpal tunnel, or can they coexist? Arthritis won't typically lead to carpal tunnel. It tends to be its own kind of thing, but they certainly can coexist, meaning, carpal tunnel is something that we oftentimes see as we age. It happens, 30 or 40s, 50s, 60s, etc. So with aging, we also tend to get arthritis. So having coexisting arthritis and coexisting carpal tunnel is very, frequently seen in my practice. All right, guys. Well, that wraps up tonight's webinar. If you think you're having these symptoms and you want to schedule an appointment, the link is going to be here below so that you can schedule an appointment with me. I'm in Mooresville. We have practices all over, Charlotte into South Carolina. You can also use the Hurt app if you want more information, but this will be posted to a lot of our social media platforms. So if you want to watch this at a later date, you absolutely can. Thank you all for tuning in and taking the time to ask those questions. That was great. I really appreciate y'all, and I look forward to seeing you soon.